Hello there, my name is David Leonard and I'm one of the doctors from Lincoln County Hospital. Today I'm going to give a talk about intracerebral hemorrhages. So the aim of my talk is to differentiate between the three most common causes of intracerebral hemorrhages, which is subarachnoid, subdural and extradural hemorrhages. Let's start with a case. So case 1. This is a 40-year-old lady with a background history of polycystic kidney disease and no other medical history. She comes on with a sudden onset headache in the occipital region. She describes it as an intense headache, the worst headache she's ever had in her life, and it's like being kicked in the back of the head. It reaches maximal intensity within seconds to minutes, and after that moment it settles down. So this is a subarachnoid hemorrhage. Before we go into why we came to that conclusion, let's look at some anatomy. So this is the layers of the meninges and the outer layers, the bone and skin. So let's start from the outside. So there's the skin, periosteum, the skull, and the meningeal layers, which is the dura mater, arachnoid, and pia mater. So subarachnoid hemorrhage occurs between the arachnoid layer and the pia mater. So why did we come across that conclusion for subarachnoid hemorrhage? Well, if we looked at her history, she's got a history of polycystic kidney disease, which predisposes people to have binary aneurysms, and if they rupture, it can cause a subarachnoid hemorrhage. And it's the most common idiopathic cause of subarachnoid hemorrhages. In fact, trauma is actually the biggest cause for all subarachnoid hemorrhages. Its presentation is normally a thunderclap headache, and it's the worst headache which has ever happened. It reaches maximal intensity within seconds to minutes, then settles down. So in terms of managing these type of patients, you want to do an ABCDE approach, and then you want to do a CT head. So what comes up in a CT head depends on the severity and how big the bleed is. As you can see in this arrow, there is a hyperdense lesion in the middle of this image, suggesting a bleed. In 5% of cases, a bleed won't show up on a CT head. In this case, you want to do a lumbar puncture. You do a lumbar puncture 12 hours post headache, and what you're looking for is the breakdown of red blood cells called xanthochromia. So let's discuss management. We can either take a conservative or surgical approach. Discussion with neurosurgery is needed. The things which they look at is comorbidities, whether they're fit for surgery, or how severe the bleed is and how much it's affecting the patient. In medical management, day 4 post-headache, you would give the patient nimidipine. This prevents vasospasm of the blood vessels in the brain, which could cause brain ischemia. In surgical management, neurosurgeons tend to go for endovascular coiling and clipping to prevent any further rebleeds. Let's go to a second case. So this is an 84-year-old lady. She lives at home by herself. She comes in with her son with a 2-week history of increased confusion, which fluctuates, and increased drowsiness. She has a generalized headache, and son reports that she's had a fall 2 weeks previous. And son mentions that at this fall, she did hit her head. The kind of findings you'll find on CT is a hyperdense crescent-shaped lesion, as you can see in this scan on the left hemisphere. This is a subdural hematoma. As you can see in this image, it's causing a mass effect with the squishing of the ventricles as shown there, and the movement of structures to the other hemisphere. Back to our anatomy diagram, subdural hematomas can be found in between the dura mater and the arachnoid space. So how do we come to this conclusion? Well, subdural hematomas normally affect the elderly and alcoholics. The reason why this is because of brain atrophy. So in the elderly and the alcoholics, they have brain atrophy, and there are bridging veins which are found between the dura sinuses and which go past the dura space. These are stretched and has a lot of tension due to the brain atrophy and can rupture quite easily due to any trauma. How do we manage these kind of patients? So we take an ABCDE approach, as all patients, and we have to do the CT head. And a CT head, as discussed previously, you'll get a crescent-shaped hematoma. So management. As for all bleeds, you'll need to discuss with neurosurgery, and they will give advice whether we take a conservative or surgical approach. The surgical considerations which neurosurgery will consider are clot line thickness greater than 10 millimeters, any midline shift greater than 5 millimeters, any signs of brain herniation, or any drops in GCS from baseline by 2 points. Let's talk about the conservative management. If a patient is deemed for conservative management initially, they will be monitored with GCS and neurological OBS. If the patient has the neurological OBS and they deteriorate or the neurological OBS worsen, they will need serial CT heads to see whether the hematoma worsens. Surgical management is as per NICE guidelines, and I've mentioned the 3 options which they may cover, which is doing a burr hole, craniotomy, or cranionectomy. Let's go to our final case. So this is a 22-year-old gentleman presents to A&E following a trauma incident earlier on the day. He was playing a cricket match and was accidentally hit with the cricket bat across the side of his head. Initially, he felt quite dazed, but after 10 to 15 minutes, he was fine enough to go home. When he went home, his flatmates noticed that the patient has become increasingly drowsy and less communicative. So this is an extradural hemorrhage, or history for an extradural hemorrhage. As you can see here in anatomy, the extradural space is actually a potential space, it's not a real space, and it's in between the dura mater and the skull. On CT head, you can see a biconvex shaped lesion on the right hemisphere, which is hyperdense. So this is an extradural hemorrhage. So pain is typically over the lateral aspect of the head, and this is where the pterion area is. And this is a weak part of the skull where 4 bones join together, which is the frontal, temporal, parietal, and sphenoid bones. Underneath this area, superficially, there is the anterior branch of the middle meningeal artery, which ruptures and causes the bleed into the extradural space. So the typical history you will have in these cases is a transient loss of consciousness or transient decrease in GCS. So like in this case, patient initially felt quite drowsy, quite unwell. Then you'll get a lucid interval where patient's back to normal. Then you get a latent decrease in consciousness. So management of this case has all the other cases we mentioned today. It's an ABCDE approach along the guidelines of ATLS. Then you want to do a CT head, which will show a biconvex lesion, as shown in the previous slide. And finally, you want to go for surgery where you can evacuate the lesion. So this is just a summary slide just to compare the 3 types of hemorrhages. So starting from subdural, so typical presentation is a gradual loss of neurology over a few days or a few weeks, typical in alcoholics and elderly. Extradural is caused by trauma, where you have a lucid interval of normal consciousness before a decrease in consciousness afterwards. And finally, subarachnoid hemorrhage, typical history is a thunderclap headache which reaches maximal intensity, which is key, within a few seconds to minutes, and may or may not have signs of meningism. So in terms of imaging, so the typical CT appearance of a subdural is a crescent-shaped. Extradural is a biconvex shape, and subarachnoid, well, it depends on the size of the bleed. Finally, just talking about what causes the different bleeds, subdural is caused by the rupture of the bridging veins due to extra tension. Extradural is caused by rupture of the middle meningeal artery, the anterior branch. And finally, subarachnoid, well, it's caused by trauma, but berry aneurysms are one of the most common causes. Thank you for listening today. I would encourage any questions. You can email me on davidleonard@nhs.net. This talk was filmed in Lincoln, October 2015, and was based on NICE guidelines and up-to-date as a resource. We would encourage you to look at current evidence before making any decisions for patient care.